Behind the Knife, the surgery podcast. Relevant and engaging content designed to help you dominate the day.
Hello again from the University of Michigan, Department of Vascular Surgery. I'm Luciano Del Bono, and I'm joined by my co-resident Andrew Huang, as well as our program director, Dr. Bobby Beaulieu.
Howdy. All right, man, what do we got on the docket for today?
Okay, so today we're going to flip the script. We should start off by recognizing that this is a surgical podcast, and most of this conversation is going to be about avoiding surgery. That said, today's discussion should hit on some really high-yield, hot topics that everyone should be aware of. Now, most listeners will already be aware of PAD and its impact affecting millions, limiting mobility, and quietly raising the risk of heart attack, stroke, and limb loss. For decades, medical management has relied solely on aspirin and statin therapy, but today the landscape is changing. From PCSK9 inhibitors that drive cholesterol to record lows, to GLP-1 agonists like semaglutide improving walking distance, to novel antithrombotic strategies, PAD care is entering a new era. And perhaps more importantly, these are therapies that are being advertised to your patients already. So they're coming to clinic asking about them. There are countless Insta posts, commercials, and even influencers discussing the use of these medications for other purposes. So today we'll explore the breakthroughs, the evidence behind them, and what they mean for patients who just want to keep moving forward, managing their PAD with a prescription pad instead of a scalpel. So to kick us off, Andrew, can you please give us a brief overview of the major tenets of cholesterol management and why it's so important for our patients?
For sure. Standard medical management of PAD typically focuses on smoking cessation, blood pressure management, sugar management, and lipid controls. Major medical societies from the AHA to the SVS consistently emphasize reducing saturated fat intake, recommending that it make up less than 6 to 10% of your daily calories, depending on individual risks. That's because saturated fat typically raises LDL, the so-called bad cholesterol, promoting atherosclerosis and worsening vascular disease. It does this by disrupting liver cholesterol processing and downregulating LDL receptors, which means more LDL stays in the bloodstream, contributing to plaque formation. Meanwhile, unsaturated fats do the opposite. They help clear LDL from circulation by upregulating these receptors. However, LDL is not the whole story. There is emerging evidence that measures other lipoproteins such as apolipoprotein B levels that correlate with cardiovascular outcomes even more tightly. That said, one thing we have consistently seen is that the lower the LDL levels, the lower the risk of cardiovascular outcomes. And this has led to the SVS recommendation of treating all symptomatic PAD patients with statins.
Yeah, Andrew, this is actually pretty interesting because I have a number of patients that come into clinic now, and they have these markers that have been got from either doing blood tests on their own through some commercial company or from their cardiologist, and they actually want to know what the interpretation of their LDL and ApoB levels are. So I really hope we can dive into some of what we should be doing for these patients.
Yeah. And that's what we'll talk about for the next 30 minutes here.
I know it can be pretty tough for them to connect the dots and talk about maybe our recent landscape of what this may be more difficult.
Especially with the recent landscape with a lot of confusing comments such about animal fats, beef tallow, and other dietary changes. This is really important time for physicians to make sure that there's a good understanding of what data is actually available so that we can properly communicate it to our patients. We're often the ones that have to have this face-to-face conversation with patients, especially vascular surgeons who may sometimes see these patients more often than their primary care providers.
Okay, so just let's break this down really quickly between beef tallow. What is it? What's it made of? And why has it become such a controversial topic in the nutrition world?
Oh, man, are you targeting out the vegetarian in the group? All right, man. Well, beef tallow, let's just first of all say this. It's going to be impossible to address many of the claims that exist out in the ethersphere about some of the dietary changes you can make. So let's just focus this a little bit on what we know about how they can affect your cholesterol levels and how that may lead to different cardiovascular risk. And we'll kind of tie it in with the PAD aspect of it too. So beef tallow is the rendered fat from cattle. It hurts me just to say it. And it's commonly used in cooking and frying. What makes it nutritionally significant is its fat composition. So it's made up about 50% saturated fat. And I think most people are pretty intuitively taken aback when they hear that number, because we know, and we've been ingrained with these USDA guidelines, that saturated fat should make up less than 10% of your daily calories. And that's from a young age onwards. All right, so one of the key arguments that people often make in favor of beef tallow is that it contains a fatty acid called conjugated linoleic acid, or CLA. Some early animal studies, like one by Hubbard et al. That we'll link to in the show notes, suggested that CLA might improve insulin sensitivity or even reduce cancer metastases in mice. I haven't treated very many mice, and so here's where the problem lies. These findings haven't been replicated in humans, and the amount of CLA used in those studies were much higher than you'd ever realistically get from eating beef tallow. You'd need to consume around 11 tablespoons of beef tallow daily just to match the CLA dose used in those mice. And even then, the health benefits remain unproven. Meanwhile, what is very well established is the health risk associated with saturated fat. We outlined the link previously, but basically, saturated fat impairs uptake of LDL from the bloodstream by the liver. As a result, you have higher levels of circulating LDL, and these can contribute to atherosclerotic plaque development. Another thing I hear a lot about is beef tallow kind of being a more natural food. I'm sure y'all have heard this. It's kind of like the push we're all making to eat more naturally right now. And the thought is that by being less processed than other quote-unquote seed oils, it may make it intuitively healthier, and that it's more stable at high heat and doesn't oxidize as easily when frying. Well, what we've seen is that doesn't necessarily translate to health benefits. It's also been shown that plant oils like olive oil and canola oil actually remain relatively stable when you heat them up once or even twice. It's these repetitive cycles of heating that seem to destabilize these and lead to the oxidation. These plant oils, like olive oil and canola oil and flaxseed oil, are actually rich in the unsaturated fats that we talked about before, which may have a role in reducing LDL levels by upregulating the liver's processing of them. They also have fatty acids like alpha linoleic acid, or ALA. This is found in things like flaxseed, chia, and walnuts, and has been shown to lower LDL levels and reduce cardiovascular risk. So overall, beef tallow is not a health food. Yes, it's stable for frying and contains a few minor fatty acids with theoretical benefits, but none of those benefits have been demonstrated in humans, and none of them seem to outweigh the well-documented cardiovascular risk of saturated fat. We've also seen a lot of villainization of the so-called seed oils, but to be honest, the data don't really support the risks that are discussed. If anything, there's an overall net benefit from the use of these oils, like olive oil, which has been shown to improve endothelial function and nitric oxide release, and even canola oil, which has had mixed results but has not shown an adverse effect, especially when you consider using these oils at so-called normal levels or to replace other foods that would have had higher saturated fat content. So if you're looking into what fats help to support your health, I think the data pretty consistently point more towards the seed oils than they do towards beef tallow.
Yeah, thanks, Bobby. So let's try to bring this back to PAD. Specifically, I want to look at some of the effect of cholesterol on measurable cardiovascular outcomes, and want to get more towards some of the trials that have come out recently and influenced our decisions, such as the Fourier trial. So when we think about cholesterol management in patients with atherosclerotic disease, the Fourier trial is one of the landmark studies that has changed our approach, and it was published in 2017 by 17 and colleagues. So this was a large, randomized, double-blind, placebo-controlled trial that enrolled over 27,000 patients with established atherosclerotic cardiovascular disease, i.e. people who had prior heart attacks, strokes, or symptomatic PAD, all of whom were already on statin therapy. And their question was simple but profound. If we lower their LDL cholesterol even further, can we reduce the cardiovascular events even more?
But I thought like statins were kind of our best line therapy right now to help lower cholesterol levels. What did they look at to get this done?
Yeah, so to test this, patients were assigned to either receive evolocumab, a monoclonal antibody that inhibits the PCSK9 enzyme, or placebo, both on top of their background statin. PCSK9 normally inhibits the LDL receptor in the liver, marking them for destruction. By blocking PCSK9, evolocumab effectively rescues these receptors, allowing the liver to clear much more LDL cholesterol from the bloodstream. That ends up resulting in LDL levels plummeting by about 60%, from around 92 milligrams down to an astonishing 30 on average. Importantly, this degree of LDL lowering was achieved safely. Nearly 90% of patients got their LDL levels below 70, and 2/3 even dropped below 40 without an increase in neurocognitive issues or hemorrhagic strokes. The relationship between LDL and cardiovascular risk was strikingly linear, meaning the lower the LDL, the lower the risk.
Wait, so how low can you go? Can I have an LDL of 10 and live forever? Or?
Well, we really haven't bottomed out at this point, so we don't know what the lower limit is. When it came to outcomes, evolocumab made a real difference. The primary composite endpoint, including cardiovascular death, MI, stroke, hospitalization for unstable angina, or coronary revasc, was reduced by 15% compared to placebo. The secondary endpoint of cardiovascular death, MI, or stroke was reduced by 20%. These benefits grew over time, suggesting that the longer patients stayed on the therapy, the greater the protection. The effects were consistent across all subgroups, meaning those also with PAD, diabetes, and even patients whose LDL were already relatively low at baseline. In PAD specifically, this translates to fewer heart attacks, strokes, and likely a slower progression of limb ischemia and vascular events. So essentially, to summarize, the 4-year trial confirmed that high-risk patients, particularly those with PAD or other manifestations of cardiovascular disease, by adding a PCSK9 inhibitor like evolocumab to maximally tolerate statin therapy, you can deliver substantial reductions in their cardiovascular risk. It also reinforced the principle that lower is better when it comes to LDL, and we really haven't established a lower limit. Achieving those levels once thought to be dangerously low can, in fact, both be safe and profoundly protective. So for our patients with PAD already at the highest risk for cardiovascular events, the 4-year trial tells us that aggressive LDL lowering with statins plus PCSK9 inhibition isn't just safe, it saves lives and limbs.
Yeah, and I think we need to temper that trial just a little bit with some of the cost data. That these are real expensive therapies with estimated yearly costs of over $14,000. And depending on how you look at the outcomes is going to impact whether or not you think this is a cost-effective therapy. We actually have 2 big trials that have looked at this, and one looking just at the cost of the therapy has said this is probably a little expensive. It needs to get closer to $9,600 mark a year to be a cost-effective strategy for our patients, while others have looked at the impact that either limb loss or a cardiovascular event has on a patient's ability to generate an income and the quality life years lost, and say, hey, this is an effective strategy that is both medically effective and cost effective. So I don't know that the jury are out on what's going to necessarily be the right number, but I'd say in a lot of patients, this is a good strategy that makes both economic and, as you pointed out, medical sense.
Today's episode of the Behind the Knife podcast is brought to you by Gore Medical Products Division. The right dialysis access is a question that depends on each patient's age, anatomy, and medical history. The National Kidney Foundation's updated KDOQI guidelines recommend patient-first, individualized care that helps to preserve vessels for future access creation and avoid unnecessary procedures and complications. With Gore Dialysis Access Solutions, you can achieve and maintain reliable arteriovenous access quickly while adhering to the updated guidelines. See how at goremedical.com/dialysis. That's goremedical.com/dialysis. Intended for U.S. audiences only, Gore is a financial sponsor of this podcast, which has been independently developed by the presenters and does not constitute medical advice from Gore. Always consult the instructions for use prior to using any medical device.
So I think this would be a good time to talk about another class of medications that's in our vascular medical toolbox here, and that's going to be the GLP-1 agonists. In particular, we're going to take a look at the STRIDE trial, which is a recent trial from 2025. This incorporated GLP-1 agonists, think of Wegovy or Ozempic, into our daily or medical regimen here. This was a phase 3B double-blinded randomized trial of nearly 800 patients with intermittent claudication. And for some of the listeners here, these are patients who could still walk but are limited in their walking distance by leg pain. These patients received either semaglutide, which is a GLP-1 agonist, or placebo for 52 weeks.
Yeah, and I think, Andrew, it's probably important to butt in here and just talk a little bit about the motivations behind this trial. So I would be surprised if any listener of this podcast hadn't heard of either Wegovy or Ozempic or Mounjaro, and that's because these GLP-1 agonists have become such important medications to help both diabetic patients and those without diabetes for weight loss. But mechanistically, it actually does a lot more than that. So GLP-1 is an incretin hormone. It enhances glucose-dependent insulin secretion, reduces glucagon release from the liver, slows gastric emptying, and that's how it mitigates a lot of its effect with weight loss. And it even acts in the brain to reduce appetite, kind of the two-hit hypothesis that allows for it to be so effective in weight loss. But beyond glucose control, it's thought to improve endothelial function, reduce oxidative stress, and promote vascular health. And so for a while, there's a few factors with GLP-1 that seem to be pointing towards its effectiveness in this high-risk patient population that we're talking about, those with PAD.
Yeah, and that's what the STRIDE trial found as well, that patients on semaglutide with intermittent claudication were able to walk further and longer without pain compared to those patients who were getting the placebo. Their quality of life scores increased. They had fewer needed rescue therapies with medications such as silastazol or pentoxifylline, and fewer of them went on to require revascularization, which not all the vascular surgeons might be excited to hear. This study wasn't, though, powered for major limb or mortality outcomes, and all the trends leaned in favor of semaglutide. Importantly, it was well tolerated, and only mild GI side effects were slightly more common in these patients. In context, in earlier PAD trials, silastazol was able to improve walking distance by about 43 meters, and semaglutide in the STRIDE trial was able to achieve a similar magnitude improvement, but with much broader metabolic and vascular benefits in comparison. In fact, this impact was significant enough that the European Medical Agency recently updated the Ozempic label to include data from the STRIDE trial for use in the PAD, and the US FDA decision is expected later this year on this topic. Clinically, the STRIDE trial represents a major step forward. It's the first trial to show that a therapy can improve walking performance and quality of life in diabetic PAD, which suggests that a GLP-1 receptor agonist may protect the vasculature in ways that go well beyond glucose or weight management, the initial targets for this medication. So together, trials such as the FOURIER and STRIDE trial are really redefining what medical therapy has classically meant in PAD, not just slowing disease, but actually helping patients live better and walk further.
Okay, so mechanistically, we understand that decreasing saturated fats also helps decrease your LDLs, which improves your cardiovascular function. So, Bobby, what do you do clinically?
Yeah, I mean, I think one of the most exciting things about this is there's a lot more tools to be able to treat our patients before we ever get them to the operating room. So when I see a patient in clinic who's got PAD, which the SVS currently defines as an ABI less than 0.9, and symptoms like intermittent claudication or rest pain, there's a pretty easy checklist to go down to make sure that you've maximized the medical therapy first. So these patients should be on a statin therapy, sort of hitting that LDL lowering goal that we just talked about. We'll get back to just what I do in a second if that's not effective. But there's a couple other easy ones. If they have other indications for being on a beta blocker, I'll make sure that they're on that. They should be on an aspirin 81 milligram monotherapy, or if they've had difficulty tolerating aspirin, we can switch to a Plavix monotherapy. I won't do some things like start silastazol right away because those patients should be confirmed they don't have congestive heart failure, as there's a black box warning for the use of silastazol in patients with congestive heart failure. But there's a couple easy things to just go through like we just talked about. Now, once we've had that initial conversation, and so we've touched on the topics like what their dietary habits are like, are they smoking, can they stop smoking, and whether or not they have good blood pressure control, I want to see how far they're walking typically. And that walking distance can be something they subjectively report, or it can be something where they've undergone supervised exercise therapy and we have a report on how far they're walking. But you want to get an idea of where they stand baseline. It's at this point that you can really start talking to them about some of these other therapies to help improve their walking distance, like the semaglutide or Ozempic, or you can start talking to them about whether or not they need to go on something to buffer the effect of that statin and allow their LDL levels to be even lower. And that's where the evolocumab comes into the conversation.
Bobby, do you typically order labs such as LDL or other biomarkers like that regularly in clinic, or do you do it selectively on patients?
I mean, it's kind of hit or miss. I feel like if there's a patient that you have a good relationship with, the surgeon is in a really unique spot to be able to sort of catalyze that change. You're often even saying, hey, listen, you've got to undergo a major surgery in which we either do some sort of endovascular therapy or an open bypass, or we can start with these medications, and I need to get the information appropriate to be able to know what medications are right for you. And given that choice, a lot of people would just kind of choose the easier side up front. I mean, I probably do the same thing.
And do you have a typical algorithm that you kind of work through in how you prescribe some of these cholesterol lowering medications, and even taking into consideration whether or not they have intolerance to them?
Yeah, that's a really good question. So in clinic, I have no problem prescribing statins. And I think most surgeons should be empowered to prescribe statins. The rates of myalgia are quite low. And what we initially thought were high rates of liver dysfunction manifest by liver enzyme rises on a check that's typically done in 3 months, they just don't seem to be as high of a risk anymore. And so often what I'll do is I'll start them on a high intensity statin. And the AHA actually has pretty clear definitions on what a high intensity statin is. That's a atorvastatin, or Lipitor is its trade name, at 80 milligrams for patients that are 75 or younger. And then once they're over 75, that high intensity dose becomes 40 milligrams. And then by the same metric, it's Crestor 40 or 20, and Crestor is rosuvastatin.
What if patients don't tolerate either of those? Is there good data on any of the other statins, or should we just move on?
Yeah, I mean, the key thing to do is you can often find something within the class of statins that they'll tolerate. The bigger wall you'll often run into is patients have tried a couple statins, and that's kind of it. They don't want to try another one because of either myalgias, or they did have that rare liver enzyme rise. And those are the ones who you're thinking, Ezetimibe maybe. Start them on some Zetia and see if maybe you can help to reduce their cholesterol that way. Or if you want to go down the evolocumab route. Now, I'll be honest with you, I'll often work with their PCP or their endocrinologist in order to start working on some of these. And that's not necessarily because it's a big hassle anymore, which it kind of used to be to get these approved through the insurance, but now that's quite easy. It's because, you really want to make sure that you're doing this in conjunction with excellent blood pressure control, discussions about changes in their diet, good blood glucose control, and whether or not you want to add on something like the semaglutide that we talked about. And so these are conversations that should exist outside of just the bubble of surgery and really expand to their whole health landscape.
Yeah, it really does reinforce the fact that these patients are complex patients with complex medical care and really need a village in order to make sure that they stay healthy and progress well through all their other medical problems.
Yeah, you're absolutely right. And I mean, I think this should really empower the surgeons listening amongst this to take hold of the reins, because we can really help to drive better outcomes for a lot of these patients who are referred to us. Oftentimes, if you're a vascular surgeon, they're referred to you with the idea of you're going to revascularize this patient. And I can't tell you how many are actually happy when they know that there's some medical therapy options that can keep them from having to go to the operating room.
Mm-hmm. Okay, so it sounds like we have a pretty comprehensive plan on how to treat these patients, walking through different algorithms of statins, biologics, and even including not just the surgeon, but also the primary care physician. So just want to say, dominate the beef tallow. I mean,
what? Come on, man.
Sorry.
Dominate the day.
And go blue.
Be sure to check out our website at www.behindtheknife.org. Download our free app available for Apple, iOS, and Android. Simply search for Behind the Knife in the App Store or Google Play to download the app. In the app, you can listen to our episodes, watch high-yield videos, and even access our premium content, including our oral board reviews and trauma video atlas. You can also follow us on Twitter at Behind the Knife and on Instagram at Behind the Knife Podcast. If you like what you hear, please be sure to leave us a review. Content produced by Behind the Knife is intended for health professionals and is for educational purposes only. We do not diagnose, treat, or offer patient-specific advice. Thank you for listening. We appreciate your support.
Until next time, dominate the day.